Thank you for joining us for this session focusing on nursing's role in multiple system atrophy, or MSA. Note that this session is really for those without much prior knowledge of the disease. Specifically, we're going to be talking about the role that nurses can play in the diagnosis and management of MSA. I'm Bagchi, a professor at Rutgers University and a family nurse practitioner in New Jersey. I'm also the medical power attorney for my mother, who was diagnosed with MSA in her mid-60s. Before we get started, there are two important disclaimers I would like to share. First, I have received no compensation for my role in developing and presenting the session's contents. Second, while I am the medical power of attorney for my mother, someone living with MSA, the content of this presentation is based entirely on peer-reviewed literature and not personal experience. Let's start the session with an overview of the learning objectives. We're going to start with a description of MSA and its epidemiology in the United States. We will then move on to a discussion of the defining characteristics of the two variants of MSA. We'll review the 4 levels of diagnostic criteria. We'll contrast the features of MSA versus conditions with similar etiologies and symptoms, namely Parkinson's disease, Lewy body dementia, and progressive supranuclear palsy. We'll discuss the goals in the management of MSA so that you can work with patients and their caregivers to establish priorities for care. We'll talk about some of the important discussions to have with patients, family members, and other healthcare professionals regarding end-of-life care for patients. Finally, we'll wrap up with some recommendations for increasing awareness of MSA among key stakeholders, including other medical professionals. Let's start with some basic facts. Most importantly, what exactly is MSA? First of all, it is rare. It is a condition that affects people of all genders and ethnicities with an incidence in the United States of approximately 3 cases per 100,000 population and a prevalence of 2 to 8 people per 100,000. Second, it is progressive. Typical onset is in the 50s and 60s. There have not been any cases confirmed before age 30, and onset after age 75 is considered late onset. Mean survival is around 9.8 years, with survival longer than 15 years very rare. Third, MSA is considered a sporadic condition. Research has not been able to conclusively identify any environmental risk factors. And while there have been some studies suggesting a genetic component, heritability is estimated at only 2 to 6%. Finally, MSA is a neurodegenerative disease. Its cause has been identified as deposits of alpha-synuclein in the glial cells of the brain. Alpha-synuclein is a presynaptic neuronal protein associated with synaptic vesicle transport and neurotransmitter release. Accumulation of alpha-synuclein is also a process seen in Parkinson's disease. However, while the alpha-synuclein deposits in Parkinson's disease accumulate in the nerve cells themselves, in the case of MSA, these accumulations occur in the oligodendrocytes, the cells within the brain that are responsible for the production of myelin, the insulating layer or sheath that forms around nerve cells. As alluded to earlier, there are 2 common variants of MSA. In MSA predominantly Parkinsonism or MSA-P, the areas of the brain affected are usually the dorsal lateral putamen and caudate nucleus. And the primary etiology is striatonagral degeneration, that is disruption in the connection between the 2 areas of the brain, the striatum and the substantia nigra. In MSA-P, the alpha-synuclein aggregates have been seen to be more ribbon-shaped, and MSA-P is the most common variant in most countries. In MSA predominantly cerebellar or MSA-C, the areas of the brain affected are the cerebellum, specifically the Purkinje cells, the vermis and the dentate nucleus, the pons, specifically the pontine basis, and the medulla, the inferior olivary nucleus. The primary etiology is oliviopontocerebellar atrophy. In the case of MSA-C, alpha-synuclein aggregates have been seen to be more fibril-shaped, and AC is the most common variant in Japan. Diagnosing MSA can be quite difficult. There are currently no laboratory or imaging studies that can, by themselves, provide a definitive diagnosis. Findings are often normal or equivocal in early stages of the disease. The earliest signs, specifically erectile and/or urinary dysfunction and orthostatic hypotension, often precede a formal diagnosis by several years. Diagnosis, therefore, is based on clinical features assessed through a detailed medical history and supported by other diagnostic evidence. Prior to 1989, the only diagnostic criteria were those established by the Mayo Clinic. There were two prior international efforts to establish diagnostic criteria. The first was published in 1999 and the second in 2007. Earlier this year, the MSA Criteria Revision Task Force, convened by the Movement Disorders Society, published the third consensus criteria, which established the following 4 levels of diagnostic certainty: neuropathologically established, clinically probable, and possible prodromal. We'll discuss each of these categories in the slides to follow. For a neurologically established MSA, a diagnosis can only be made on autopsy. Brain tissue samples will demonstrate the presence of abundant and widespread alpha-synuclein glial inclusions throughout the central nervous system, and either striatonegral degeneration in the case of MSAP or oliviopontocerebellar degeneration in the case of MSAC. Making a clinical diagnosis depends on the presence of 4 factors: at least one of 3 core clinical features, along with either Parkinsonism or cerebellar signs, at least one of 13 supportive clinical features, and at least one of 3 markers identified by MRI studies. Prior consensus criteria mentioned a number of red flags or conditions that were more frequently associated with MSA than other disorders. So I'm going to review 3 of these because they were specifically mentioned in the most recent consensus criteria, as summarized on the previous slide. The first is disproportionate antipolis or dropped head sign. This is defined as pronounced forward flexion of the head and neck in relation to the trunk, and without evidence of associated weakness of the neck muscles. The second is a Pisa sign, defined as lateral bending of the trunk with the tendency to bend to one side, like the Leaning Tower of Pisa. Finally, there's the hot cross bun sign, which is described as the appearance of a cross similar to that seen on hot cross buns, which appears on MRI in the area of the pons. A clinically probable diagnosis uses the same categories of criteria as a clinically established diagnosis, but the criteria are more relaxed. In this case, a patient would just need to demonstrate one of the 5 core clinical features and at least 2 of the supportive clinical features. In this case, the presence of MRI markers is not required. As an aside, note that under the core clinical features, the definition of cerebellar syndrome only requires one of 3 common presenting signs: gait or limb ataxia, cerebellar dysarthria, or oculomotor features. For clinically established diagnosis, at least 2 of these features should be present. The final category of diagnostic certainty is possible prodromal. These are signs and symptoms commonly seen in the early phases of the disease process. This diagnosis requires at least one of the following: REM behavioral disorder, defined as a physical acting out of vivid, often unpleasant dreams with vocal sounds and sudden, often violent arm and leg movements during the REM phase of sleep. Neurogenic orthostatic hypotension, where the autonomic nervous system loses the ability to properly regulate blood pressure and the patient experiences a drop of 20 millimeters of mercury systolic blood pressure or 10 millimeters mercury of diastolic blood pressure. Or urogenital failure, that is urinary incontinence or retention, the latter defined as a post-void residual urine volume greater than 100 milliliters. And either Parkinsonian signs such as muscle rigidity, impaired posture or balance, and slowed movement, or cerebellar signs, ataxia, loss of balance, intention tremor, and nystagmus, or involuntary rhythmic side to side, up and down, or circular motion of the eyes. There are a number of factors, if present, that can help to exclude an MSA diagnosis. These include meaningful response to levodopa, especially for patients with MSA-P. You may see an early response to levodopa, but the effect will usually wear off after a few months. Unexplained anosmia. Patients with Parkinson's disease often lose their sense of smell, but this is uncommon in patients with MSA. Cognitive dysfunction relating to attention, alertness, and visuoperceptive abilities. Cognitive functioning usually remains intact in patients with MSA. Visual hallucinations that are not drug induced within 3 years of symptom onset. Patients with MSA generally do not experience hallucinations. Dementia within 3 years of symptom onset. Dementia is less commonly a feature of MSA than with other similar conditions. Down gaze supranuclear palsy, defined as an impaired voluntary vertical gaze, especially downward, with preservation of reflex vertical movements, or also known as doll's eye maneuver. This is suggestive of a diagnosis of supranuclear palsy and not MSA. MRI imaging suggestive of an alternative diagnosis, or any alternative diagnosis that is consistent with common symptoms of ataxia, autonomic failure, or Parkinsonism. So if any of these signs or symptoms are present, the patient is unlikely to have MSA. This table is by no means comprehensive, but it shows some factors to consider when attempting to differentiate MSA from Lewy body dementia, Parkinson's disease, and progressive supranuclear palsy, also called PSP, the 3 most common misdiagnoses for patients with MSA. Notice that 2 of our red flags are listed here. Disproportionate antipolus dropped head sign occurs in Lewy body dementia and PSP as well, but is rare in Parkinson's disease. And the hot cross bun sign is common in MSA, especially MSA-C, but is not entirely absent in other disorders. Treatment options for MSA are relatively limited, but primarily target symptoms. To date, there have been limited studies of patients living with MSA, and in most cases, patients with MSA are a subgroup of larger studies that focus on several neurodegenerative diseases. As such, many of the current treatment recommendations, particularly medications, are based on evidence from studies conducted among patients with similar or related disorders. In most cases, the evidence base for MSA treatments is founded on uncontrolled trials, retrospective analysis, case reports, and expert opinions. Keep in mind that even commonly recommended medications can have serious side effects for patients with MSA. For example, dopamine agonists may reduce some Parkinsonian signs, but can also worsen orthostatic hypotension and increase the risk of falls. Similarly, muscle relaxants may ease the pain of muscle contractions, but can also lead to an increased risk for falls. Finally, midodrine, an alpha adrenergic agonist that increases peripheral vascular resistance and is used to increase blood pressure, may raise blood pressure, but can worsen supine hypertension. A common recommendation is to first discontinue or change any medication that may worsen MSA symptoms. For example, anticholinergics may increase urinary retention, which many patients already deal with. Lifestyle changes can be very beneficial. Eating smaller, more frequent meals can reduce postprandial hypotension. Using abdominal binders with meals can also help reduce postprandial hypotension. Increasing sodium intake to more than 8 grams per day can increase blood pressure. Raising the head of bed while sleeping can reduce morning hypotension. And exercise and physical therapy are recommended to increase blood pressure and reduce muscle stiffness. As symptoms progress, patients may need more invasive interventions such as clean intermittent catheterization to treat urinary retention. There's no cure for MSA, therefore, effective management of MSA requires a well-integrated and multidisciplinary team centered around the needs of the patient and their caregivers. The role of primary care providers is critical because they often see the earliest manifestations of disease and serve in the role of care coordination. A neurologist is an important member of the team to assist in making a formal diagnosis and managing disease complications. Urologists can help in the management of erectile and urinary dysfunctions. Physical therapists can assist with strengthening exercises to help address ataxia. Many patients develop speech and swallowing disorders, which can be addressed with the assistance of speech therapists. As noted previously, REM sleep disorder is common in the early phases of disease, and many patients experience problems with insomnia, which can be managed by sleep experts. Patients with MSA frequently experience constipation, which may become intractable to common treatments. In these cases, a gastroenterologist can be a helpful member of the team. And patients may suffer from depression due to loss of function, quality of life, and poor disease prognosis. So it can be helpful to involve social workers and other mental health specialists with disease management. Finally, as we'll discuss more in the next slides, palliative care, pain is often undertreated in patients with MSA, and the need for end-of-life necessitates the involvement of palliative care specialists. However, it's important to note that many people have misperceptions of what palliative care is. Discussions with patients and their caregivers, it may be helpful to talk about palliative care as supportive care. It's important to emphasize that palliative care is about improving quality of life. It's not about withdrawing life-sustaining care and services, and is not the same as hospice care. Patients may require palliative care services for several years before end-of-life care discussions become necessary. Many experts recommend initiating palliative care services immediately upon diagnosis. However, even after clarifying what palliative care services can provide, patients and/or their caregivers may not be ready to initiate these services. There are several other points in patient's disease progression or triggers when it might make sense to try initiating the discussion again. An obvious point is whenever the patient or caregiver broaches the topic. Other potential triggers include when symptomatic treatment fails, when the patient starts to have frequent emergency department visits, or when the patient starts to experience prolonged or frequent hospitalizations. Topics to address in discussions of palliative care services include the patient's prognosis, the patient's and caregivers' goals of care, the importance of establishing a healthcare power of attorney or proxy in anticipation of the time that patients are unable to speak for themselves, symptom management and specialty referrals, the need for educating others, which may include friends and family, but even other healthcare providers, daycare services and activities, spiritual needs, and documenting preferences. So this type of documentation includes establishing advanced directives regarding preferences, for example, intubation, tracheostomy, and artificial nutrition when the patient's respiratory or swallowing functions begin to fail, do not resuscitate orders, and the preferred place of death. The most common causes of death in patients with MSA are sudden cardiac or respiratory failure and pneumonia. A particularly difficult topic to raise with patients and caregivers is the question of brain donation. There are two primary reasons why a patient or their loved one may want to consider a brain donation. First, as was mentioned previously, the only way to make a definitive diagnosis of MSA is through autopsy. And second, brain donations can support future MSA research. There are a number of important facts to know about brain donation. First, an open casket is still possible. The brain is removed through a small incision in the back of the head, which is not noticeable in an open casket presentation. There may be a cost for the brain removal, which is usually done by a technician or a pathologist. Costs can range from $500 to $2,000, but there may be ways to offset these costs. But there is usually no cost for the actual autopsy. Critical to understand is that brain retrieval needs to occur within 24 hours of death. So early planning is really important. Finally, if the patient's goal is to contribute specifically to MSA research, it is important that the receiving brain bank be one that participates in MSA research. The list of brain banks is available at the hyperlink and is listed on a later slide as well. This particular site is searchable for locations that do MSA research. MSA research is exploring a number of promising advances. Although considered a sporadic disease, research is looking into possible genetic mechanisms for disease processes. Advanced computer techniques are allowing for the development of more sophisticated modeling of disease etiology and progression. Machine learning is providing more advanced and precise imaging to assist in earlier diagnosis. Promising research is looking at the potential for biomarkers to enhance differential diagnoses. And as we learn more in these areas, we can hope to develop more targeted and effective treatments. There are a number of things that everyone can do to increase MSA awareness. Advocates have called for March to be declared MSA Awareness Month. Many states and localities across the United States have taken up this call. The link here provides guidance on how to request an MSA awareness proclamation in your area. Other ways to support MSA awareness include hosting the MSA Awareness Shoe. This effort started as a prank among a group of friends, one of whose mother, Pearl, was living with MSA. One of the friends decided to steal a shoe from another friend while he was sleeping. And the friend started a social media page to document the travels of the Defeat MSA shoe as it was passed around the neighborhood. A few days into the prank, Pearl's daughter, Gretchen, told her friends that when she showed the social media page to her mom, Pearl laughed for the first time in months. Today, there are 7 MSA awareness shoes, one for each continent, and they travel around the world helping to raise awareness of MSA. Rock musician Vince Neil from Motley Crue appeared on an MSA awareness billboard in Las Vegas in 2017, so advocates are working to raise awareness through more extensive billboard promotions. At the international level, October 3rd has been declared World MSA Day. Participants are asked to walk or bike a mile and light a candle at 8 p.m. local time with the goal of a stream of candlelight circling the globe. There are a number of resources you can consult for additional information. The MSA United International Consortium is a global consortium of charitable associations united in their dedication to fight MSA. The Defeat MSA Alliance is a US-based nonprofit organization staffed entirely by volunteers that supports patients, educates medical professionals, raises public awareness, nurtures promising research, and advocates for the MSA community. The MSA Trust is the UK and Republic of Ireland's leading charity supporting people affected by MSA. Dysautonomia International is a nonprofit that seeks to improve the lives of individuals living with autonomic nervous system disorders through research, provider education, public awareness, and patient empowerment programs. Finally, several organizations offer information and resources to assist in the process of brain donation. To highlight how MSA may present, I wanted to review a case study. Sheila D. is a 65-year-old woman who presented to her primary care provider after a fall from her bicycle. She reports that she had several dizzy spells and has fallen from her bicycle at least 3 times in the past year. About 1 year after her first fall, she started occasionally using a cane for stability. She's always had low blood pressure, 90s over 60s, and was diagnosed with Sjogren's syndrome at age 61. She does not currently take any prescribed medications, and her husband reports that she has recently started calling out and flailing her arms when she's sleeping, and that her speech has become, quote, different, unquote. Her physician ordered an MRI to rule out a brain tumor, which revealed shrinkage of her cerebellum. So what are some of the possible indicators from this case study that Sheila may be in the early stages of MSA? She's been having dizzy spells and falls that have become more frequent. She's always had a relatively low blood pressure, but she has become symptomatic. The sleep disturbance sounds like REM behavior disorder. She's taken to using a cane due to gait instability. So what is her likely diagnosis? Clinically established MSAC. What diagnostic criteria does she meet? She meets all the core criteria. She's been experiencing orthostatic hypotension and has evidence of cerebellar syndrome. She meets the supportive criteria. Symptoms have progressed rapidly over the past year. And she has at least one MRI marker, shrinkage of her cerebellum compared to prior MRI studies. Nurses are ideally suited to play a critical role in the diagnosis and management of MSA. First, nurses are often the closest points for patient care, so they may be in a better position to recognize the earliest symptoms of MSA. Early recognition can promote more timely and effective differential diagnosis. It also prevents errors in management that can actually worsen symptoms. As we mentioned before, levodopa can decrease blood pressure, which can be dangerous for patients for whom hypotension is already one of the more common manifestations of disease. Nurses, especially nurse practitioners, are ideally positioned to serve as care coordinators. Primary care nurse practitioners already serve as care coordinators in primary medical home models. And registered nurses and nurse practitioners may also be working in specialty care settings where they can raise awareness of the needs of patients with possible or probable MSA. Nurses are especially adept at meeting the palliative care needs of patients and caregivers. With specific training and expertise in active listening and patient-centered care, nurses can serve as a critical resource for patients and caregivers dealing with a deadly progressive disease. Finally, several international experts in the field have called the need to raise awareness of MSA across medical professions as one of the quote-unquote critical needs for the field. It is hoped that this presentation will provide nurses with the preliminary resources they need to become effective patient advocates, another role for which nurses are ideally suited. Thank you for attending the session. On behalf of people living with MSA and their caregivers, I hope you feel inspired to learn more about how you can help in the early identification and management of this deadly disease. Please reach out to me with any questions.